Hello, my good people, and welcome back to another exciting episode of the NailedIt Orthopedic Podcast. I am Dr. Jay Fitz, and I also have with me.
Dr. Wendell Cole.
All right, guys, we are back at it, and we have another great talk in store for you guys. This one is probably going to be a little funny, but I'm gonna let Dr. Cole kind of just go ahead and introduce things, and we'll tell you a little bit more about it.
Oh yeah, guys, we have a good episode for y'all today. We're talking about femur fractures, and funny thing, when we actually made this episode, we'll say we were juniors, we a little early in our orthopedic career.
Pretty
And
early,
Dr.
guys.
Bernstein.
Pretty early.
So Dr. Bernstein asked us a couple questions here that we didn't necessarily know the answer to, but it was great. It was a learning experience. Definitely just kept it in. I know I had a few laughs going back and editing this episode. But let me tell you guys a little bit more about our guest, Dr. Mitchell Bernstein, who we have with us. He is an orthopedic traumatologist. He did his medical school at Chicago Medical School. Did his residency at McGill University up in Montreal, in Canada, and is still practicing now in Canada. And I actually met him during our AO basic course. We actually go there as interns. And I met him, and he was part of my group, one of our group leaders. And he did a great job. Was very thorough with his explanations. A really fun person to be around, a really person to hang around and learn things from. So really enjoyed making this episode. Really enjoyed listening to it, editing it. So I'm hoping you all enjoy this episode.
You are now listening to Nailed It, the Orthopedic Surgery Podcast, featuring Doctors Jay Fitz and Wendell Cole.
Bernstein. So welcome. Thank you for coming on the show. We're
pleasure
really
to be here.
Have you here.
Thank you very much. Pleasure to be here.
Oh yes. I remember I enjoyed. I met you at AO Basic in our recent course in San Diego, and I enjoyed having you as a lecturer and having you as our group discussion. So I figured it'd be great to come on here and talk, and really look forward to talking with you today.
Thank you. You were clearly one of the best participants at the course.
Oh,
and a lot of the faculty were discussing how phenomenal you were, actually.
Oh, I hope so. That'd be nice. Thank you.
All right, now hold up. I don't know, Dr. Bernstein. He didn't pay you to say that, did he? I don't know.
No, this is. I cannot discuss the conflicts at this point. Let's stick with the topic here.
All right. So we typically start off asking just a couple questions, just getting to know you as a person. And, the first thing I'll actually start off with is, so what actually made you want to be a teacher and instructor at the AO basic trauma course, or, in general?
So the AO course or becoming AO faculty has been really phenomenal for me, because basically, every time I go to a course, I actually learn myself. So you're with friends, colleagues, mentors, and eventually you get to be a mentor. But you do a lot of faculty development. They teach you how to be a better educator. You can speak to your colleagues about cases, difficult cases, challenging problems. So besides just your passion for teaching, it's really phenomenal just for career development.
All right. Well, that sounds pretty good. So on kind of somewhat on that same type of subject, why did you choose trauma as a whole to go into as a specialty?
So I like complicated problems. I don't know why, but I like complicated problems. I thought trauma was the best subspecialty that would allow me to deal with patients that had complicated problems. Trauma, I think, lends itself to thinking. It's different surgery every time. These patients come in with devastating injuries, and then there you are to try to help them get back to what they were before the injury. So it's something that you could take very seriously and have that motivate you to be really an expert in your field. So that's why.
Awesome. And for the last question, we tend to ask, something outside of orthopedics. So, what are some of your interests outside of ortho?
I like accounting, believe it or not. I like law, and I like economics. um, so I'm very interested in how the healthcare system works. I also like cycling and hanging out with the family.
Oh, nice. I have my significant other. She really is into cycling. Are we talking about like at the gym, kind of the like the class, or is that what you're talking about?
I'm talking about both. I mean, I think I like outdoor cycling a little bit better, just because you're out there for 2-3 hours and you really can decompress out there. It's like a form of meditation.
Well, I suggest keep doing it. Just the other day, I had this guy, 81-year-old guy, came in with an ankle fracture. He does like 50 miles every so often, a couple times a week. And I mean, he came in, he got his ankle fracture. This will tell you a lot right here. He got his ankle fracture from playing volleyball. He said he ran into somebody playing volleyball. So it's good for you.
Yeah.
80 years old.
Yeah, he was like 81. Healthiest patient on my list right now. All right.
I like it.
I do.
Well, perfect, man. So let's hop into the topic of the day. Today we're going to talk about some diaphyseal femur fractures, and we always kind of just like to start off with a case, and then we'll kind of walk through it. So let's say we have a 35-year-old patient who comes in after a motorcycle collision. He's coming in with right thigh pain, has an obvious deformity about that right thigh. What are some things that we want to go ahead and have on our minds? Say we get this call, at 1, 2 in the morning or whatever time. What are some of the things that we want to have our mind? And when we see this patient, what are some of the things we kind of want to start to think of?
So number one in trauma, it always holds true. You want to make sure the patient is okay and alive. So the way to do that typically in a trauma scenario is what's called the ATLS protocol. So, if you're taking an oral exam or actually taking care of patients in front of you, you want to make sure make yourself aware of the ATLS algorithm. So that's the first thing you want to make sure. You want to make sure the patient's breathing, there's not other associated injuries. And they don't have to be musculoskeletal injuries only. Again, you want to make sure the patient doesn't have a brain injury, chest injury, etc. So that's basically the first thing I would look at.
And so once you do that, we go in there, GCS is 15, they're up, they're talking to you, but they're just still complaining of pain. What are some of the things that we want to kind of key in it on when we start to do a physical exam?
So you want to try to get yourself focused initially away from his obvious deformed femur. So, you mentioned, especially when presenting the case to me, you said he has an obvious deformity. So the problem with that is if you're either a novice examiner, you're a junior resident, you don't want to focus on the obvious things, because that's easy to do, right? If it's an obvious deformity, you're going right to it. So what I would suggest is, for a minute or two, don't focus on the obvious deformity, and then make sure he doesn't have any other injuries. That's what I would do first. So you're palpating other parts of his body, the entire body, and make sure nothing else hurts him. And then you can focus on his limb that's injured.
Absolutely. Well, I like that idea. I think, like you said, I think that's a huge thing that I still, to this day, I have to make a point. I have to make a point to myself to, hey, even though all this, is open over there and it's clearly broken, let's not go to that part until last, just to make sure you don't miss.
That's an open fracture is very easy to deal with, right? An open femur fracture, you're going to deal with it. That algorithm is very easy for you to do. Anyone can learn that. The art of it is making sure it's not an open femur with a knee dislocation, open femur with a vascular injury, open femur with a contralateral calcaneus fracture. That's what will make sure you take care of your patients well.
Okay. But all right. So I think that's a huge point to not miss out. And say when we finally do get to that obvious deformity, what are some of the things that you kind of look for just on a physical exam for this type of patient?
So you want to make sure there's no open wounds. So you got to look circumferentially, make sure he's appropriately disrobed. You want to make sure the patient has their garments taken off. So that rules out if it's an open injury. You want to check for compartments, regardless of an extremity that you think has a low incidence of compartment syndrome. You still want to check for compartment syndrome. And that basically entails palpation. And if patient has a GCS score that allows for assessment of pain, make sure the patient doesn't have too much pain for what you would expect. And then you want to check the vascular status of the limb. That's by palpating pulses. And then check the neurologic status of the limb by checking known nerve function in the foot in this case.
So say, we do our physical exam, his nerves are intact. Now, what type of imaging do you want say, for example, you have a resident coming to you and saying, this is what we have. What is the imaging that must be obtained? And what are you looking for exactly on this different imaging?
What imaging would you want? Am I allowed to do that? Am I allowed to throw back a question?
You're doing the boomerang here.
I like
boomerang.
I like it.
Well, okay, I'll answer the question. Why not? So, of course, we want full-length femur films. We want the joint above and the joint below. The real question I had is how often are you getting CT scans in patients that have, femur fractures? That's what I wanted to get your opinion on.
Okay. So what are you getting a CT scan for? Or what are you getting a CT scan of? You're asking, are we getting a CT scan of the whole femur?
Exactly. Yeah. So how often are you getting a CT scan of the femur, in
zero time? Why are you getting a CT scan of the femur is the question.
So say you had a concern for femoral neck fracture, you had a concern of some other occult fracture. Is there a time to get a CT scan?
Okay, so that's a good question. It's a fair question. So again, anything we do, you want to get a sense of what the, like why you're getting the test. So I wouldn't order a CT scan of the femur. The question really is, should we be getting preoperative CT scans of the femoral neck to rule out a femoral neck fracture? So I don't routinely do that. I think X-rays are sufficient. With that said, some of these patients, if they have a CT scan of their chest, abdomen, pelvis, it usually includes cuts through the femoral necks on both sides. So it behooves you to actually look through them to make sure there isn't a femoral neck fracture. But part of your preoperative planning is intraoperatively making sure you check also at the end of the case if there is a femoral neck fracture.
Okay, awesome. So that's a good way to move on to the next part. So we'll say we've gotten the appropriate images at this point. We've looked at the X-rays. We decided we don't need a CT for this. No way that we're going to get that right now. We got the appropriate X-rays. We got the pelvis, the full femur, the knee. As far as treatment, where do we go from here? We can say for our particular case that it is a mid-shaft femur fracture, closed mid-shaft femur fracture. And, we can kind of go through how your approach would change depending on if it was a little bit more proximal versus distal, depending on where that fracture is.
So a mid-diaphyseal fracture for a trauma surgeon is a emotionally pleasant case. Pretty easy, relatively speaking. Nothing's easy, but relatively easy, at least emotionally. And that's treated with an intramedullary nail that's statically locked and reamed, I would say almost all the time.
Now, are you going, what makes your decision versus going to retrograde versus Antegrade? And for those that may not exactly know the benefits of reaming, what can you kind of touch on why reaming and kind of what that does for your fixation and for healing?
So Going antegrade versus retrograde is, I would say, a surgeon preference. Surgeons will argue retrograde nails are better because you don't have hip pain. Surgeons who like antegrade nailings argue, well, I don't like to go through the knee joint and potentially damage the articular surface of the knee joint. So it's supported both ways. If you have a mid diaphyseal fracture, to go antegrade or retrograde. With that said, I prefer antegrade always, unless there's a reason to go retrograde. Reaming increases the size of the nail that you can use, right? So reaming basically opens the intramedullary canal in a cylindrical fashion to accommodate the size of the nail. We typically ream 1 millimeter above the definitive implant. Some surgeons ream 1.5 millimeters above the definitive implant.
And can you walk us kind of through antegrade nailing, like, some of the basics, some of the things people should know as far as like piriformis start versus, greater trochanteric start, and the difference between the two, and, some of those specialized nails.
So you're right. There's two nails that has to do with the start point. Both start points need to get you into the medullary canal. So the advantage of a piriformis start is that true or false, J fits. Okay, this is for J. True or false, J fits. Yeah. Is the piriformis fossa collinear with the medullary canal of the femur?
Yeah.
Am I allowed to? I don't want to put him on the spot here. Is this okay to do?
Fine,
cool.
It's great. I'm loving it.
I'll take that. Is it collinear? Is it collinear? I'm gonna say that not exactly, but it's more collinear than, say, if you were going towards versus like the some kind of like a greater troch starting point. I think you're a little bit more in line with the actual canal that way. So I don't know.
Okay, so I'm not gonna, because are you a millennial? Because you're a millennial. I'm not gonna say you're wrong. Okay, I'm not gonna say you're wrong, but what I would have preferred you said was it's exactly collinear with the medullary canal.
There you go.
See how I frame that? Because I don't, millennials, you can't be too aggressive with that. So the piriformis fossa is collinear with the medullary canal. So it's a straight shot. So in that sense, it's, quote, easier to get your alignment or some components of your alignment. The greater trochanter entry point is off axis. And that's why the nails for a greater trochanter are bent at the top, right? To accommodate the fact that you're starting off axis like a tibial nail. So the greater trochanter nails are popular because they're said to be easier to actually get your starting point. That's why some surgeons prefer a greater trochanter starting point. The downside is it's not collinear with the canal, and therefore can be more difficult in certain fracture patterns, such as subtrochanteric fractures, to get your coronal alignment, especially accurate.
Okay. So
Jay, I apologize about putting you on the spot. I feel bad right now.
I kind of like
He's
it.
okay.
I kind of like it. I shine in moments like these. It's fun.
There we go. There we go.
I shine in moments like these. I was born for this. No, but really. So, okay, we just kind of went through, the starting point. What's, in your opinion, what's some of the things that's going to lead you down, going greater troch versus piriformis, or is there just one that you prefer at all times?
I always prefer a piriformis fossa entry point nail, just because I think I'm focused more on the the accurate alignment, and I just think it's easier to ensure that the femur is aligned, especially the AP angulation, if you use a straight shot.
Now, if you have a patient, say BMI 55, is it? What are the difficulties, I guess, in still doing the piriformis start? Because, I was reading and it was saying that.
Okay, yeah, that's a very good question. Very good question. So, at that point, you need to position the patient such that you can actually get access to the starting point. In those cases, your skin incision for your starting wire needs to be extremely proximal. So if your patient's not positioned or draped appropriately, you won't be able to get the starting point. So it can be very challenging. And the other option is you can go retrograde. So if you have a patient who has a big BMI or large BMI? Large BMI?
I think large BMI, high number.
Large BMI, high BMI, BMI of 55. Now, a relative indication for a retrograde nail would be that. So you could go retrograde, and that could help you stabilize the fracture. But yes, that's also an indication where a greater trochanter starting point may be easier, although still will be challenging.
Now, one of the things I wanted to just quickly touch on regarding the antegrade nail before we get to the retrograde is, we're reading that, they have these specialized nails that have a lateral proximal bend. Can you kind of describe like the function or, what the use of that is when the surgeon is using that greater trochanteric start?
So again, because you're not entering the femur collinear with the canal, and because you're off axis, the nail has to be bent, right? So the nail is bent to accommodate for the fact that you're not entering through the piriformis fossa. So it typically has a bend, of 7 to 11 degrees, depending on the manufacturer, for the first, I don't know, I think it might be 10 centimeters. Don't quote me on that. But for up into the subtroch region where you're entering, there's going to be a lateral bend to the nail to accommodate that.
Okay. And when we talk about retrograde nailing, can you kind of give us like some of the key pearls, like where's the starting point for this, and just kind of a little bit about the technique of this set.
Okay, so good question. So let's say we put J Fitz inside the medullary canal, the femur. Okay, he's inside the canal. Let's say we push him up proximal. Where will he exit, anatomically speaking?
Proximally along the piriformis fossa.
Exactly correct. Exactly. Okay. So, and that goes to the point we were just discussing. The piriformis fossa is collinear with the medullary canal. So the question is, well, let's say we took J and pushed him distally through the medullary canal. Where would he exit at the level of the knee joint or at the distal femur? Like, where would he come out? And that's basically the entry point. Agree?
Yeah, absolutely.
So I'll just tell you, the entry point happens to be collinear with the medial tibial spine and not at the center of the intercondylar notch. So that's point number one. Or you may hear some arthroplasty surgeons tell you to drill when they're doing a total knee using intramedullary referencing where the PCL insertion is. But if you're imaging for trauma circumstances, it's collinear with the medial tibial spine, which is just medial to the center of the intercondylar notch. That's your entry point. The other concept is, and this is a little bit confusing, but it is what it is. There's a trajectory to your entry point. Like at the proximal aspect, if you're going antegrade, there's no trajectory because you're just aiming, down. It's a straight shot, and you're constrained in a good way by the piriformis fossa and the proximal femur. Like you can't really go to medial, go to lateral, you're going to perforate the canal. So you're forced to go down a set path defined by the anatomy. Do you know what I mean by that? That makes sense?
Yeah, it makes sense. Yeah, for sure.
Okay, so if you're going retrograde, you have a large metaphyseal region, so you can have a trajectory that's basically whatever you want. And that's bad. Okay, so the basically you're going at an angle of about 81 degrees, and that's an angle off the entry point. So your entry point wire and a line across the distal femoral condyles. So if you drew a line tangential to the condyles, your entry point should be 81 degrees. The lateral angle should be 81 degrees to that. You may also hear it as 9 degrees off the perpendicular, which is sort of, it's confusing, and you may need to draw it out for it to make sense, but 81 degrees off a line tangential to the femoral condyles.
Okay.
Now, I had to have a quick question on that, because actually I'm on joints right now, and I was actually just reading not too long ago about the femoral axis and that number.
Oh boy, that's a whole nother podcast.
Oh man, just really quick on that number 89 and 9 degrees. So the number
81 and 9 degrees.
The number 9 degrees was significant because they were saying the axis of the femur is about 6 degrees valgus, but then now if you go down to the transepicondylar region, or the condylar region, there's another 3 degrees of valgus there, making the entire degrees 9 degrees. Is that kind of the same? No, it's something different.
That's confusing. No, it's different. And it to be honest, it takes a while to really understand all those numbers. If you're excited or motivated for deformity like I am, it's a whole different language. So it really has to do, and you guys can look it up, or the viewers could look it up. We're talking about the anatomic lateral distal femoral angle, the ALDFA, versus what's called the mechanical lateral distal femoral angle. And what you are referring to is what's called the AMA, the anatomic mechanical angle. And that's the difference between the mechanical and the anatomic axis, the femur, which typically is about 6 degrees in valgus. But I don't really want to get into it more because it's very confusing,
right?
Especially if you're not looking at pictures of it.
Right.
Okay. Yeah, we was about to go off into a whole another side of things.
Yeah. It's but the point, the point is, and again, that's why I prefer Antegrade. You could see if you, and again, Cole and Jay, I guess, and all the viewers out there. Is it a viewer or something? What do you call a person listening? Listeners. Okay, all the listeners. If you want to do the surgery properly, which nail requires more thinking?
Well, just kind of going from what you've been giving us, it sounds like the retrograde would require.
Exactly. Yeah, exactly. Sure. The retrograde's giving you. I'm not going to swear, but the retrograde's giving you a headache.
Right.
You're getting a headache from how the hell do I get this entry point and trajectory done properly in a distal femur that has a big metaphyseal region, and using a C-arm that I can't see the medullary canal because it's too far proximal. Mm-hmm. So I actually don't know where to aim my wire to go into the femoral canal, right? You could deviate a couple degrees.
And so let me ask that. So say for some of the more distal, non-articular femur fractures, to control that the distal piece, you still prefer going antegrade versus retrograde?
No. If it's a distal fracture where my fixation distally is going to be compromised, or I'm not going to feel comfortable, then no, I'll go preferably for a retrograde nail because I just think it's a better construct. If not, some sort of plate and screw fixation. Okay.
And like when I say that, I don't know, it's not distal to the point where it's involved in the joint, but I know we're kind of talking about mid-shaft fractures, but I want the fracture to kind of be down there. And I just want to know, you still tend to go, sound like you're saying that you're more likely to head towards retrograde at that point.
Yeah.
Okay.
That's true.
That's good. Let me see. And I think the only other thing that we just wanted to talk on, can you speak on going reamed versus non-reamed? I know there's some difference in opinions on that as well.
To my knowledge, reamed nails would be the standard. I don't know of any one of my colleagues that would ever do an unreamed nail.
Okay, sounds good. I don't know. I guess maybe
like just to keep it simple. And yeah, I think the standard of care would be reamed nails. That goes for tibia and femur, at least within my sort of friendship circle, North American, talking about North American trauma surgeons.
Right. And so really quickly on positioning, can you quickly go over it? Kind of what's your preferred position for, doing these femurs?
My preferred is on a radiolucent table, flat top table, supine with a little bump under the buttock. Patients brought over to the side of the bed, and I use a ramp to elevate, an elevator ramp under the ipsilateral extremity. And then I have a sterile traction setup for intraoperative traction where I put a 2 millimeter wire in the distal femur, use a sterile rope over a traction bow, over a pulley system that's also becomes sterile, and put like 15 pounds of weight at the end of the bed. That's my preference. Other positions you could do is a lateral position, and you can use obviously a fracture table, which a lot of surgeons prefer.
Okay, great.
Never any manual traction?
So I joke around with the residents. I like to have a civilized surgery where the residents are. I like it to be civilized in that the less the surgeon or the residents are physically doing, like for prolonged periods of time, the better. So I like to free up people's hands, meaning I want to position the patient so that, you don't have an assistant holding the leg.
Yeah.
Whether it's rotation or traction or a bending moment the whole time. So I try to use, bumps, traction, positioning pillows, etc., just to free up people's hands during the case. Just because, it's irritating, but there's a fatigability to it. It's awkward, and it's hard to maintain during the entire case, right? Especially when you're imaging, you're going to a lateral, etc.
Totally agree. I should have did my rotations with you as a fourth year.
Yeah, you can come. I'm in Canada. We're more than welcome to come here.
And in patients that, these polytrauma patients, patients that have, like lung contusions and concomitant injuries, what's kind of your thought process behind, okay, we'll just do an Excfix for temporary stabilization versus we can just go ahead and insert a intramedullary rod at this point?
Yeah, so there's that's a whole different topic in and of itself. Tons of literature on that, which I would encourage your listeners to look into. So basically, it comes down to still, unfortunately or fortunately, you have to talk to your colleagues. And I'm talking about the anesthesia team, the general surgery team, the ICU team, and potentially neurosurgery team, to see how sick this patient is. And there's a lot of metrics or clinical parameters that we can use to determine if you should go in or not. So I'll just say that. I tend not to do an Excfix. I think if the patient's really sick, I think just skeletal traction in the ICU for a day or 2 or 3 is good. Mm-hmm. Sometimes the Excfixes are actually a lot harder to do properly than you think. It's not hard to put an Excfix on a femur, but if you take an X-ray after the Excfix and you see the femurs in 2 different time zones, then what actually have you done? And when you did the AO basic course, you realize how unstable a femur fracture is in an Excfix, because you're so far away. Even if you put the bar is very close to the skin, you're very far away from the bone. Mm-hmm. That's my bias. With that said, it's still very appropriate to put a temporary Excfix on a femur fracture in certain circumstances. I would say, such as, let's say, you had a very sick patient who couldn't get an IM nail but had a vascular injury, and you need to stabilize the bone. An Excfix would work there. If you had a significant open fracture, an Excfix would work there, and still appropriate to use it as a temporizing fixation.
All right, I like it. I think this was a absolutely wonderful talk. I feel like it's going to be one of our tops.
Stellar talk, guys. It's probably gonna be number one. Just
I can feel it.
Keep me updated with the viewers, but it'll be number one.
I can feel it. Now,
Mind you, you know what? I don't want to sound. Listen, I'm in Canada. I don't want to sound like Trump. Not to talk about politics here, but I don't want to be too positive about the podcast. But it's going to be phenomenal.
All right, sounds good. But before we go, we always like to give our listeners a way to reach out to our guests. If there is different platforms that you have, such as social media, Twitter, Instagram, something like that, is there any way for our listeners to reach out to you, Dr. Bernstein?
There is no way they can, unfortunately. I am not on social media. I'm at McGill University in Montreal, Canada. They can always look me up there, and my email is listed in our faculty section.
Now, thank you all so much for listening to yet another episode of the NailedIt Ortho podcast. We hope you guys enjoyed it and learned something. And please, 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 if you haven't, please go and leave us a review. Give us a star rating or 5 stars, however much you think we're worth. Hopefully it's 5 stars. And follow us on Instagram at NailedIt Ortho. And you can also go to NailedItOrtho.com for the show notes. Okay. You all have a great day.